My name is Luis Richard, English Technical Teacher John Moscoso. Tema parcial oral versus intravenous antibiotic treatment of endocarditis. Definition. Endocarditis is inflammation on the inner lining of the air chamber and valves. Connected endocarditis. Usually this inflammation is caused by a bacterial infection, which grows into valvular vegetation, and the bacteria that causes the dissection are Streptococcus and Staphylococcus, and is rarely caused due to the fungal infection. Diagnostic video.
The pathogenesis of infective endocarditis begins with damaged heart valves from congenital heart disease, rheumatic fever, IV drug abuse, and the placement of intracardiac devices such as implantable defibrillators and pacemakers. Valve damage leads to sterile deposits of platelets, red blood cells, white blood cells, and fibrin called non-bacterial thrombotic endocarditis, or NBTE. If a sufficiently virulent organism is present in the bloodstream in sufficient amounts, it may colonize the damaged valve and its associated NBTE, and now the mass of bacteria and the NBTE becomes infective endocarditis. 80% of infective endocarditis is caused by gram-positive cocci, of which Staphylococcus aureus is the most common. The HASEC group of organisms consists of fastidious gram-negative bacteria that are an unusual cause of infective endocarditis. They are, together with fungal infections, notoriously associated with large, friable vegetations, which can easily break off and cause emboli to vital organs. Enterococcus causes about 10% of infective endocarditis. Enterococcus is a notorious problem if it causes endocarditis because agents that interfere with the organism's cell wall can inhibit these organisms, but cannot kill them. However, bactericidal therapy is essential to prevent recurrence of endocarditis of any cause. Thus, for enterococcal endocarditis, potentially toxic aminoglycosides must be added to cell wall agents for the entire period of treatment to eradicate the infection. Diagnosis is confirmed by multiple positive blood cultures and visible vegetations noted on echocardiography. Definitive management of patients with infective endocarditis is best accomplished by an infectious disease specialist, and the nuances of antimicrobial therapy are beyond the scope of this lesson. However, while awaiting culture results, empirical therapy of native valve infective endocarditis with vancomycin plus ceftriaxone is recommended. For prosthetic valve endocarditis, the combination of vancomycin plus gentamicin plus oral rifampin is recommended because of the possibility of methicillin-resistant Staphylococcus aureus, or MRSA. This combination is also recommended for methicillin-resistant Staphylococcus epidermidis, MRSE. Adjustment of antibiotics can be made by an infectious disease specialist when available. In some cases of endocarditis, valve replacement early in the course of endocarditis should be considered because it is associated with a lower mortality than elective valve replacement after prolonged antimicrobial treatment. This includes patients who exhibit congestive heart failure, which is the most common cause of death from infective endocarditis. Patients with infection caused by organisms that are difficult to treat, such as Enterococcus, especially on a prosthetic heart valve, as well as Staph aureus, aerobic gram-negative bacilli, and fungi, are also candidates for urgent valve replacement. Previous cerebral embolism, or the presence of large vegetations which may embolize or compromise the heart's electrical conduction system, leading to heart block, are also indications for urgent replacement. The bottom line is this: if surgery is inevitable, early surgery has a better prognosis than delaying surgery. An endocarditis team consisting of a cardiologist, a cardiac surgeon, an infectious disease physician, a microbiologist, and an intensivist who discuss patients in the hospital with infective endocarditis weekly and make decisions about surgery has been shown to reduce mortality substantially. To complete the picture as an outpatient, follow up by a cardiology and infectious disease specialist at 1, 3, 6, and 12 months after surgery is optimal.
So I hope you liked this video. Absolutely make sure to check out the course this video was taken from and to register for a free trial account which will give you access to selected chapters of the course. If you want to learn how Med Mastery can help you become a great clinician, make sure to watch the About Med Mastery video. So thanks for watching, and I hope to see you again soon.
Aplicación en medicina, endocarditis. Pacientes with infection endocarditis on ten less siden ten are typical. Treatment with intravenous antibiotic agent for up 6 weeks. It's unknown whether and change from intravenous to oral antibiotics. 10 patients in this stable condition will result in efficacy and safety similar to 6 weeks continued intravenous therapy. Which video infection?
Infective endocarditis is infection of the endocardium, the inner lining of heart chambers and the covering of heart valves. Infection is caused by microorganisms, mainly bacteria, that have managed to enter the bloodstream. Except for rare cases caused by massive blood infections or highly virulent organisms, a healthy heart is usually resistant to infection. This is because bacteria do not easily adhere to the surface of an intact endocardium. Constant flow of blood also helps prevent bacterial attachment, and the bacteria are usually destroyed by the immune system before they can cause infection. An abnormality of the endocardium is typically required for endocarditis to occur. Major risk factors include having prosthetic valves or other intracardiac devices, congenital heart defects, heart valve disorders, hypertrophic cardiomyopathy, and previous endocarditis. Endothelial injury allows for either direct colonization by virulent organisms or the formation of blood clots, which then become the attachment site for bacteria. Infection of the endocardium occurs most often on the left side of the heart. Organisms that cause endocarditis may come from distant infected sites, such as skin abscesses or urinary tract infections, or they may enter the body through a contaminated central line or injection. Bacteria of the normal flora of the mouth can also infect the endocardium if they get into the bloodstream, such as during invasive dental procedures. Causative organisms may vary depending on the source of infection, but streptococci and staphylococci are responsible for the majority of cases. Vegetations formed by bacterial growth may cause heart valve dysfunction, which can be heard as murmurs, and may lead to congestive heart failure. Myocardial abscesses and tissue destruction may lead to cardiac conduction problems. Pieces of bacterial vegetation may break free, forming so-called emboli. Emboli travel in the bloodstream and may block arteries. Right-sided infections produce emboli that travel to the lungs, causing pulmonary infarction and respiratory symptoms. Left-sided infections can send emboli to any other organs, including the brain, kidney, spleen, and the heart itself. Tiny emboli may also travel to the skin and eyes, producing small red streaks under fingernails, on fingers, toes, and the whites of eyes. Other symptoms include fever, chills, fatigue, and fast heart rates. Symptoms can develop abruptly or gradually, depending on the type of endocarditis. Endocarditis must be suspected when fever is combined with a heart valve disorder, especially when characteristic symptoms such as reddish spots on fingers or the whites of the eyes are present. But diagnosis usually requires evidence of blood infection and imaging studies such as echocardiography to show vegetations on heart valves or damage to the heart tissues. Treatment consists of several weeks of intravenous antimicrobial therapy. Identification of the causative organism by blood culture is vital to determine appropriate antibiotic regimens. Empiric antibiotic therapy before organism identification may be necessary in seriously ill patients. Some cases may require surgeries to repair or replace heart valves. Potential source of infection must be removed.
Pros and cons endocarditis. Parte oral. Pros. Instead mouse widely using was of administration and draws. Cons is with using in paciente with difficulty, small wings, with vomiting in the inconscience. Intravenous antibiotics. Pros. Is the fastest method to introduce medication. Cons. Very fast administration can cause undesirable efectos. Video. Pros and cons endocarditis.
All right, how are you feeling today?
Hey guys, I'm Rishi Desai, the Chief Medical Officer here at Osmosis, and I want to talk a little bit about infective endocarditis today. So we're going to talk about a few different topics, the first one being signs and symptoms of endocarditis, specifically infective endocarditis. So there's an acronym, a handy acronym to kind of go through this, and it is from Jane. So just think maybe you got endocarditis from Jane, although it's not contagious. So from Jane, F stands for fevers. From R stands for Roth spots. Just think of the eye exam. O stands for Osler nodes. So I think of ow, Osler. Ow being because they're painful or tender. M is murmur, so heart murmur. Jane, so Jane, Jane is Janeway lesions. And I think, oh, just Janeway, meaning, oh, just, they're not painful, they're just Janeway lesions. So they're distinct from the Osler nodes, which are ow, Osler. A for anemia, N for nail bed hemorrhages. So I'm showing my nails, but nail bed or splinter hemorrhages they're sometimes called. And E for emboli. So sometimes you'll see embolic phenomenon on a CT scan or an MRI or something like that. And that's often evidence, again, of something that's kind of spewing off of your valve and kind of seeding other parts of your body. So from Jane are the signs and symptoms. Next, let's move down to diagnosis. And for diagnosis, you really want to, there's Duke's criteria, and many of the things that I just went over are part of Duke's criteria, specifically minor criteria. But for the major criteria, the big things you want to think about are two: blood cultures and echo. So the blood cultures, basically get large volume blood cultures, you see if anything grows out. Typically, it's going to be, something like staph aureus or staph epi or enterococci or streptococci. So those are your most common organisms. There are some very uncommon organisms that are very uncommon, but you should kind of keep a lookout for. Coxiella being one of them that often kind of people will mention because it's tested using titers. But anyway, those are the blood cultures, so you just see what the lab grows out. The other one being the echo, and the echo is actually kind of the interesting one from my perspective, because I always thought it would be a vegetation on the valve that you're looking at, and that would be like, endocarditis. Oftentimes it's something that's much more subtle, so it's like a change in the way that the valve moves. Maybe there's a new regurgitation, or sometimes it's literally just the way it's moving is a little bit more stiff, or it's not kind of moving as flexibly as it was on a prior echo. And sometimes people have prior echoes if they've had cardiac surgery or something, so you can kind of compare and contrast and say, hey, is this valve looking the same as the previous one? So those are the kind of two keys that you want to look at. And then if there's a prosthetic valve, dehiscence of the prosthesis is a classic example of what endocarditis will do. So if there's any evidence of dehiscence, then you want to make sure that you investigate for endocarditis. So those are the keys around diagnosis. And then treatment, classically, it's going to be bacterial, right? So it's going to be empiric treatment with antibiotics, and specifically something like Unison and Gent, or if you're thinking about vancomycin, it might be Vanc, Gent, and Cipro, or sometimes rifampin is added on, especially around prosthetic valves. So it's going to be some combination of those antibiotics, and usually that's just for a few days until you actually get a culture back. And once you see the culture and the susceptibilities, you can say, okay, let's just change the antibiotic regimen accordingly. That's all well and good. The key, though, is the length of treatment. And I say the key because sometimes you have to treat for a long time. And with prosthetic valves in particular, sometimes you'll treat for a long time and it still won't work. And you'll have to get a surgical replacement done. And so just keep in mind that with prosthesis, I often think of prosthesis as being kind of like plastic in a way. And antibiotics don't treat plastic very well. As you can imagine, plastic doesn't have blood vessels, so antibiotics can't get to plastic. So if there's an infection of any prosthetic material, it's very hard to treat with antibiotics alone. So usually end up having to take out that valve and surgically replacing it. So anytime there's prosthesis, antibiotics are usually going to be tried at first, and oftentimes it fails, and then you have to just surgically replace. So that's the keys on treatment. And then one clinical pearl I want to kind of leave you with is just thinking about endocarditis as being a biofilm infection. So you think about biofilms as being bacteria, and then they're stuck in this mucus, right? So essentially what happens is antibiotics have a hard time getting through that mucus to get down to this bacteria that may be at the bottom. So the key there is just length of treatment. You end up giving antibiotics for weeks and weeks, as opposed to, let's say, a UTI or something where you give it for maybe 3 days or 5 days. With a biofilm infection, usually giving antibiotics for a long period of time, because the way that we essentially try to counter the fact that diffusion is what we're kind of waiting on is we just let it last for a long time, and over time, the concentration of antibiotic around the bacteria gets high enough to where the bacteria will die. So that's why the length of treatment for endocarditis is so long. I always kind of wondered about that. It's essentially because the biofilm infection is what we're dealing with. So anyway, I will leave you with that, and I hope that helped you understand some clinical aspects of infective endocarditis. Thanks a lot. Bye-bye.
Start your free trial today at osmosis.org.
INSEM application in Ecuador, endocarditis. In Ecuador, for the treatment of endocarditis, this intravenous routine is preferred because of its maximum efficacy. Commonly used drugs are an inhibitor of cell wall synthesis, such as gentamicina, rifampicina, y otros medicamentos. Como conclusión, in the patient with endocarditis on the left side of the air was very in stable condition. Changing to oral antibiotic treatment was not being inferior to continuous intravenous antibiotic treatments. Partial oral intravenous antibiotic treatment endocarditis. Finish the video. Thank you.